Vikas Reddy, consultant intervention cardiologist at Sri Sri Holistic Hospital, Kondapur, Hyderabad. So today I would like to take this opportunity to present various perspectives on what are the uses and the indications of inclisiran. You know that ACC, EAC as well as the Lipid Association of India has formulated various guidelines to know what is the ideal goal of achieving the LDL cholesterol levels. So when compared to rest of the world, we Indians have a high risk of atherosclerotic coronary vascular disease because of the genetics, because of the lifestyle, and because of the various work stress and all. So elevated LDL cholesterol is one of the most common risk factor which we see in day-to-day scenario. Each 1 millimole, that is 39 milligram per deciliter reduction in LDL cholesterol, will obviously cause a 21% reduction in the mortality benefit. So even if you reduce 1 millimole per deciliter of LDL cholesterol, it creates a huge mortality benefit. It was proven in various trials like OSCAP, HOPE, and Prosper trials also. So this is latest guidelines. So to answer precisely what is the ideal target for LDL cholesterol, there is no ideal target. The lower the LDL cholesterol, the better the life will be. So according to the 2023 ESC guidelines as well as CSI, that is the Cardiac Society of India 2023 guidelines, the target should be less than 55 milligram per deciliter for high risk patients, and those who suffered a second cardiovascular events within the 2 years of the prime event, the LDL cholesterol goal of less than 40 is ideal. Whereas according to the 2022 ACC guidelines, LDL cholesterol of less than 55 is target, and whenever we see the cholesterol, more than 50% reduction of the LDL cholesterol from the baseline should be the target according to the ACC guidelines. But when compared to the European as well as Western countries, we are at a very high risk of having this atherosclerosis. So in 2023, we ourselves, that is the Lipid Association of India, has provided a detailed consensus update on the what is the ideal target for LDL cholesterol. So those at very high risk, it should be less than 50. Those with extremely high risk category A, it should be less than 50 is recommended, but 30 is less than 30 is optional. For those with category B, less than or equal to 30 is the best. And those with extreme category of C, the low cholesterol, that is the 10 to 50 milligram per deciliter of LDL cholesterol, is the ideal target. So there is no significant association between the various low levels of LDL cholesterol and the safety outcomes. And one of the most beautiful trial is the 4-year trial. It's almost like 25,982 participants were participated in this trial. It showed a clear cardiovascular benefit with the inclisiran with no safety concerns. With no safety consensus with the LDL cholesterol levels. And lot of meta-analysis, lot of papers in between formulated that the lower the LDL cholesterols, the outcomes will be better. But if the LDL cholesterols are less than 10 also, there is no safety concerns, and safely we can target the LDL cholesterol of less than 10. So this is a beautiful chart showing the various adverse effects and the CPK elevations, neurocognitive, and these are almost negligible in most of the patients. We all know that inclisiran is the first SI, that is a small interference RNA therapeutic molecule, which is designed to lower the LDL cholesterol. How it acts? This inclisiran has a trinary gal NAC conjugate. It mimics the host nucleopeptide molecule. This is taken into the cytoplasm of the liver cell. It's not taken to the nucleus, it's into the cytoplasm, where it binds and inhibits the conjugation, so that the new protein and the new LDL cholesterol will not be synthesized. Whenever there is a reduction in the synthesis of the LDL cholesterol in the liver, obviously its clearance from the peripheral circulation is increased, so that there is a greater hepatic uptake of circulating LDL cholesterol, which ultimately leads to the reduction of the LDL cholesterol levels. So this is the ideal mode of action of the inclisiran. So usually inclisiran plasma levels decline in 24 hours, and after 48 hours it is undetectable in the plasma. So when come to the Indian approval, it is indicated for those with primary hypercholesteremia, in the sense heterozygous familial hypercholesteremia and the non-familial hypercholesteremia patients, or with mixed dyslipidemia as an adjunct to the diet. And those who are statin intolerant, or those whose LDL cholesterol remains above the therapeutic level despite using the maximum dose of statins, we can use this inclisiran. It can be used alone or in combination with the other lipid-lowering therapies like statins, estimate, bempedoic acid, or whom the statins are contraindicated. This is the best molecule to be prescribed. As I mentioned, it is generally useful for those patients with atherosclerotic cardiovascular disease whose LDL cholesterol remains high despite the maximum intensity statin therapy, or despite the use of estimate and the bempedoic acid. It is also useful for the patients with heterozygous familial hypercholesteremia. 284 milligrams of the inclisiran single injection subcutaneously should be given as soon as we see a patient with atherosclerotic coronary vascular disease And at the same time, after the first injection, the second injection could be given after a gap of 3 months. And from then, every 6 months, you should receive the inclisiran 284 mg subcutaneous dose. So this is the formulation where the sodium is 300 milligrams, water as a diluent, and the pH is maintained as a 7. It can be stored at room temperature. And initial dose, later second dose should be given after 3 months. And after 6 months, we give third dose. From then, every 6 months, we should receive this inclisiran molecule subcutaneously. And there's the beautiful trials of the Orion. They're like Orion 3, 8, 9, 10 trials, which I'm going to discuss in the subsequent slides regarding the safety and the efficacy of the inclisiran. So as I mentioned, how like most often patients tend to miss the doses. If any patient misses the dose in the less than 3 months, we can continue to the same schedule. If the planned dose is missed by more than 3 months, then we should restart again, starting from the dose 1, 3 months after second dose, then 6 months. So whenever we take in the PCSK9 inhibitors, we can take inclisiran immediately after the last dose of PCSK9 inhibitor like evolocumab. To maintain LDL cholesterol below the optimum threshold, inclisiran is administered within 2 weeks after the last dose of PCSK9 inhibitors. The ideal patients are those which we see routinely, that is ACS, that is acute coronary syndrome patients. So whenever you see a patient with ACS, we should order for the non-fasting lipid profile, where the patient should immediately start on 40 mg of rosuvastatin plus STMB or the 80 mg of atorvastatin plus STMB combination. Only in subset of patients like elderly patients of more than 75 years and those with stage 3 to 5 CKD, we need to reduce the dose to 20 of rosuvastatin or the 40 of atorvastatin with estimate. And those who have received the loading dose of the high intensity statin, we need to evaluate these patients. So if the LDL cholesterol is less than 55, then we can stick on to the same treatment, and we need to check after 3 months whether the LDL cholesterol is less than 55 or non-HDL cholesterol is less than 85, because that is the ideal goal we need to target. Even after the 4 weeks, if the desired levels are not reached, then we need to switch on to the next therapy, that is bempedoic acid. Again, you need to reevaluate after 4 weeks, that is after 8 weeks. Even after 8 weeks, if the LDL cholesterol is more than 55, then we need to switch on to inclisiran or the PCSK9 inhibitor, depending on the economic status of the patients. So the CSI guidelines recommend that all those patients with ACS with LDL of less than 55, which is not achieved with the high intensity statin, estimate, and bempedoic acid, the non-statin drugs like injectable monoclonal antibodies like PCSK9 or the inclisiran can be administered safely. And according to NICE guidelines, beautifully, the NICE guidelines have formulated that in those with heterozygous familial hypercholesteremia, if the LDL cholesterol is more than 4, or in those with very high risk patient is more than 3.5 millimoles per liter, and those with primary heterozygous familial hypercholesteremia, if the LDL cholesterol is more than 5 in those without CVD risk, and those with CVD risk, if it is more than 3.5, we can administer inclisiran after the statin, estimate, or bempedoic acid. The same thing, for the secondary prevention also, we can use this inclisiran. As I mentioned, if patients does not achieve this LDL cholesterol goal after the estimate or the bempedoic acid treatment, we need to prescribe this inclisiran or the PCSK9 inhibitors. So this is a table which shows the ACC expert guidelines of the target LDL cholesterol and what is the mode of treatment. It is very simple. The ideal goal is more than 50% reduction in LDL cholesterol, and the LDL cholesterol should be less than 70 is the target. If you are not achieving this target with the high intensity statin therapy, then we need to add estimab. Even though after 4 weeks we are not achieving, we can add bempedoic acid. Despite the 4 to 8 weeks of this treatment, if still the LDL cholesterol is more than 160 or the 140 according to the current guidelines, then we need to switch on to the more specific and the more aggressive therapy like inclisiran or the PCSK9 inhibitors. That is the same thing which is described in this slide. So the target should be more than 50% reduction in the LDL cholesterol, and more than the LDL cholesterol should be that final target should be less than 55 milligram per deciliter, and non-HDL cholesterol goal should be less than 85 milligram per deciliter. This is the ideal goals we need to achieve in every ACS patients. From the various beautiful trials of Orion 9, 10, and 11, which is conducted in the various subset of patients like Europeans and also in the United States and also in South Africa, where in Orion 9, the participants were majority heterozygous familial hypercholesteremia. In Orion 10, it is ASCVD patients, and Orion 11, it is atherosclerotic cardiovascular risk equivalent patients. So total time period is 18 months, and all 3 trials were completed, which have established the safety and efficacy of the inclisiran. So inclisiran demonstrated an effective and the sustained mode of reduction in LDL cholesterol with low inter-individual variability. So from the various pooled analysis of 9, 10, 11 Orion trials, we can see that there is 50.5 sustained LDL reduction after the 90 days. It is usually maintained up to 540 days, and there is almost like 52.7 reduction in the LDL cholesterol levels, and this also maintained up to 540 days. So with inclisiran as a strong complement to maximum tolerated statin therapy, almost 68% of patients achieve LDL cholesterol less than 70, and 52% of the patients achieve LDL cholesterol less than 50, which is the ideal target. And Orion 18 is the trial which is conducted in the Asian subset of patients, where they have compared the amount of reduction in the lipoprotein A as well as the LDL cholesterol levels, and it has been clearly found that inclisiran from the baseline, there was almost like 57.2 reduction in the lipoprotein A when compared to the placebo, and at the same time there is almost like approximately 41% lower of lipoprotein A when compared to the placebo. So 57% of LDL cholesterol and 41% of lipoprotein A reduction is achieved with the inclisiran, and this is one of the best molecule to treat the patient with the high lipoprotein A levels. The Orient trial is a trial which is conducted in order to assess the various atherogenic lipids and what is the role of inclisiran on the lipids. So again, this trial is carried out for 5-10 days, where they clearly compared the what is the efficacy and what is the usefulness of inclisiran. And inclisiran has reduced the total cholesterol by 33% when compared to placebo. It also reduces ApoB and non-HDL cholesterol. It reduces the lipoprotein A by 21% when compared to placebo, and at the same time, it also has modest increase in the HDL cholesterol, which is a good cholesterol, by almost like 7.5%. So this is the trial which shows the various benefits of Orion, which is almost carried for day 540 days. Now, when compared to the various adverse effects, so again, there is a pool analysis from the Orion 9, 10, and 11 trials regarding the safety and efficacy. It has been clearly shown that very fewer patients and have suffered from the diabetes, nasopharyngitis, URTI, hypertension, and arthralgias when compared to the placebo. And inclisiran is one of the best drug in terms of safety, and very few injection-related side effects have been found in this trial. Definitely, there is a long-term safety data is very evident on the inclisiran, where it is proven for up to 6.8 years of exposure. It is proven to be very safe according to the current guidelines and according to the recent trials. Orion 8 is which is an open label extension. It's a phase 3 clinical trial of the Orion 3, 9, 10, 11 of the various subset of patients to test the long-term efficacy as well as the safety of twice-daily inclisiran in those with high cardiovascular risk and those with elevated LDL cholesterol levels. And as I mentioned, inclisiran has no immunogenicity or the carcinogenic effect because the site of action is in the cytoplasm and not in the nucleus of the hepatocytes. And this is again the beautiful trial at the start of Orion 8. The data shows that inclisiran shows the reduction in LDL cholesterol, which is maintained in the long term while the patient being well tolerated. So almost there is those with the mean baseline of 113 milligram per deciliter. Of these, 78.4% of patients achieve the pre-specified LDL cholesterol levels, and 90% reach the target goals, and almost 50% reduction in LDL cholesterol levels even after the 2.6 years of exposure. So in terms of safety, it is consistent with the ON8 trial. The reaction side effects have been found in only 5.9% of patients when compared to 8.2 in the inclisiran of the pooled analysis of 9, 10, and 11 Orion trials. So in terms of efficacy and the safety, there is a strong data regarding the use of inclisiran. Now, what is the various cardiovascular outcome data with inclisiran? So the two most important trials are the Orion 4 and the Victorian trials, and where the CO2 trials are ongoing, and the results will be published in 2026 and 27. And according to the recently published pooled analysis of Orion 9, 10, 11, as I mentioned already, the safety and efficacy is clearly well established. There's a sustained reduction in the MACE events over 18 months, and the fewer MACE events have been recorded when compared to the placebo. And when compared to the various Mendelian randomization trials with 20 million years of exposure, there is a dose-dependent linear association between the absolute magnitude of reduction in the LDL cholesterol levels and there is a reduction in the atherosclerotic cardiovascular disease with inclisiran when compared to the placebo. So all these trials, all the current data clearly shows the efficacy and safety of inclisiran, and it is one of the first drugs to be started as early as possible if you don't achieve the target LDL cholesterol levels, especially in the ACS patients, even after the maximum tolerated statin therapy with ezetimibe or bempedoic acid. Thank you.